Welcome, everyone, to More Good Days, the official podcast of Haven Headache and Migraine Center. Our podcast aims to help you stay updated on the latest research, policy updates, and most importantly, practical advice for managing life with headaches and migraine disorders. This podcast is designed to provide you with valuable insights and support on your journey to more good days. We're in the middle of a 4-part series diving into the topic of women and migraine. In this last episode, we covered menstrual migraine. In this episode, we'll discuss pregnancy and migraine. And in the following 2 episodes, we'll address postpartum migraine and breastfeeding, as well as migraine during perimenopause and menopause. For this series, Isaac and I are joined by Dr. Susan Hutchinson, who's a personal mentor and an amazing clinician, and without her, Haven would not be possible. She is a clinical director focused on women's health. She brings a unique perspective to headache medicine from her background in primary care. Before helping to found Haven, she was the founder of the Orange County Headache and Migraine Center and the author of A Women's Guide to Managing Migraine. And just a quick note before we dive in, we strive to ensure that all statements in this podcast are clinically accurate, but they are not intended to be medical advice. Please consult with your provider, or if you're in California, make an appointment with one of our headache specialists at havenheadache.com.
Before we get started on this episode, I want to acknowledge that we are using the term woman to refer to folks that experience menstrual cycles and pregnancy, perimenopause, and menopause in this series. However, we do acknowledge that there are many folks who do not identify as women who may experience these cycles of life. At Haven, we strive for an inclusive environment.
Susan, thank you so much for joining us for part 2, migraine and pregnancy. Let's just start by asking, what do you typically see happens to migraine when folks are pregnant? Do they start, stop, or change in quality?
Yeah, that's a great question. I'm going to backtrack for just a moment, Isaac, and just to kind of put it out there that when you look at the prevalence of migraine in women of childbearing years, it's about 25%. So
wow.
When you look at migraine in women, it's not the same across all the age spans. So it really is high. And why is that important? Because that's a lot of women that potentially either want or could get pregnant. But here's the good news. For the majority of women with migraine, their migraines will often go away or pretty dramatically improve with pregnancy. Sadly enough, that's not true for all women, but for many women it is, to the point where I've actually had women tell me, Dr. Hutchinson, I think I'd like to be pregnant all the time. So my point for just start with that is that please, if you're a female and you want to get pregnant and you have migraine, don't be afraid to get pregnant, because in the majority of cases, your migraines will probably improve.
I guess that's how women have like 18 children. A woman who gets rid of their migraines with pregnancy. Bad joke. Okay.
There are those women that have, continue to have migraine during pregnancy. And for some, it can get worse. Susan, what do you think the dangers are of allowing migraine disease to go uncontrolled during pregnancy?
Yeah, and I think that's a great point, because I find that sometimes OBs tend to undertreat migraine, and women are told don't take anything, or at the most take acetaminophen, which is Tylenol. And yet here you are looking at, for example, let's say you had a woman with severe migraine and she's vomiting and she's getting dehydrated. That can't be good for her or the baby. Or what about increasing her risk of stroke? There's so many bad things that can happen with uncontrolled migraines. So I'm glad today we're going to focus on for the women who still do struggle with migraine during pregnancy, there are treatment options that can be safely taken.
I totally agree. I mean, we really need to keep in mind that migraine can worsen during pregnancy for some women, and really try to control that. But kind of taking a step back, what should a woman do before they even plan to get pregnant if they already have migraine? Is there anything in particular that you would want to see them do?
Yeah, ideally, if I was the one managing, let's say, a woman with migraine, I would like her to see me about 6 months before she's planning on even trying to get pregnant. Why? We probably need to do some pre-pregnancy planning. Let's say she's on topiramate, which is Topamax. I'm going to want to wean her off of that. Let's say she's on one of the injectable, we call them the CGRP monoclonal antibodies, things like Aimovig, Ajovy, Emgality, or she's going in for IV Vyepti. They have a long half-life. They can stick around for 5 to 6 months. That's probably something we want to go ahead and stop and put her on something that would be shorter acting, shorter half-life, easier to get off of. So I don't think I want to just see a woman, oh, Dr. Hutchinson, I'm pregnant. Please let me know. Again, I'm throwing it out there, but I think 6 months so we can start planning ahead. And it's not just looking at prescription medication. I want to know things like, what is your caffeine consumption? What about alcohol? What supplements are you taking? How's your sleep? Because there's other things too that we need to look at and discuss the safety and, let's say getting a woman's caffeine down to maybe at the most 2 caffeinated beverages a day, starting to, get used to not having that glass of wine at night. There's just a lot that can be done prior to actually trying to get pregnant.
Yeah, I totally agree. It takes time. And then sometimes, a patient will come in and she's surprised and pregnant, and then you kind of have to start from there. But either way, it's really important to have that conversation with the doctor.
I agree. And in some cases, if you are in an OBGYN group, sometimes there's a more high risk OB in that group. And I think ideally, again, it's a collaborative approach. So whoever's managing your headache, whether it be a headache specialist, maybe it's a healthcare provider like a nurse practitioner, a PA, a family medicine, but please have your OB work carefully with the other doctors that are part of your team.
How do you recommend coordinating between that OB and that headache specialist? Because they're two very busy folks.
Well, they are, but to use myself as an example, anytime I saw a patient who was even thinking about getting pregnant, I would immediately make sure that my consult report got to that OB, and I would try to foster that open relationship. And what's nice is when you do that, it's been so rewarding that then sometimes the OBs will start referring to me. And I think actually right now with Haven, I have at least 2, if not 3 pregnant patients, and we're actively communicating with the OB. And to me, that translates into much better care for that pregnant patient.
Now, there's quite a long history of kind of pregnancy and kind of how the FDA has dealt with medications when it came to pregnancy. Can you talk a little bit about that?
Yes, and I want to mention because some patients and healthcare providers still use the old system of rating, and it was a little too simplistic. So, for example, drugs were categorized as A, B, C, D, X. And so your ones that were A and B were considered compatible with pregnancy. C was you weighed the risk versus the benefit. X you definitely did not use. D, there was some concerns. The problem is once a medication got labeled with that rating, often it was difficult to change it when new information came out. And it just made it a little too easy to say this is category C or B. So then that was done away with. So that's not even appropriate anymore. So now we look based on what's happening. What are the pregnancy registries showing? What is research showing? So now it's not quite as simplistic. We have to look at a medication and say, okay, based on all the evidence and the research, what do we think about the relative safety of this medication? And again, there's some like topiramate, which is Topamax, and Depakote should not be used during pregnancy. There's some, like particularly the antidepressants, you weigh the risk versus the benefit. So it's not quite as easy as it used to be, but I think it's much better.
Yeah, I think it's so important how we look at medications and what we decide is okay and safe, and also having that conversation with the patient. And because there's been a lot of kind of controversy about certain medications, so I want to just get your opinions on, or your comments on, medications that we often use to acutely treat women with a migraine and their safety during pregnancy. Things like Tylenols, triptans, nerve blocks, Reglan, Benadryl. What do you think about these medications, and what do you typically use?
Well, the good news is a lot of the ones you just mentioned that are ones that we feel comfortable using. When I say we, I've been part of a group of providers with the American Headache Society. We really looked at this, and we actually have a PowerPoint that we can put on for different medical groups looking at this. But also since then, the American College of OBGYN, they actually have some guidelines about what they think is safe, and we've really been lacking that. And fortunately, one of the women on this committee I was on with the American Headache Society is a prominent OBGYN. So here's what I can tell you. For acute treatment of migraine, women can certainly take acetaminophen, which is Tylenol, with or without caffeine. We sometimes forget, caffeine isn't the bad monster it's made out to be. Caffeine in moderation can help headache. And so I know a lot of OBs are okay as long as the woman's not averaging more than maybe 2 caffeinated beverages a day during pregnancy. So what I would suggest is if a woman really wants her cup of coffee or tea, great. but don't have the second serving unless you need it, and then take it with acetaminophen if you have a headache. What you don't want to take, particularly during the first trimester, is aspirin, unless you need to be on very low dose aspirin for prevention of certain things, sometimes a stroke or a miscarriage. But regular adult strength aspirin, do not take. Also, don't take your normal non-steroidals, whether it be over-the-counter prescription. You should not be taking things like Aleve and Motrin. So then you're kind of coming down to the acetaminophen with or without caffeine. You mentioned Reglan, which is metoclopramide. It's an anti-nausea medication, but it also can help migraine. So Reglan is a great option. And Benadryl, which is diphenhydramine, which is over-the-counter, that also can be used during pregnancy.
We see that there are many options now, and I think that's really important to let our patients know, because sometimes they're afraid to get pregnant because they're worried about what they can take during pregnancy.
Absolutely, and I know studies have shown that some women delay pregnancy because of that, which is really a shame.
Yeah.
The other one I forgot to mention was the category called the triptans. Triptans have been around in this country, at least the first one, sumatriptan, since 1992. And you have these things called pregnancy database registries. So women that, let's say they didn't know they were pregnant, or they did, and they took it, and it gets reported. And the good news is, in all the pregnancy registries, most of which have been closed by now because the triptans have been around so long, there doesn't appear to be any signal of a problem for the mother or the baby. Having said that, if I had a pregnant woman who was needing too much of a triptan, I would want to get aggressive with prevention. But I think it's good to know that the triptans in general are considered compatible with pregnancy.
I'm curious, specifically, you talked about this resource. Where can people find more information for themselves or for their doctors about which medications are considered more safe or less safe based on that registry?
I don't know if it's publicly accessible. I think it is, but you could look at ACOG, which means American College of OBGYN, ACOG, and look under pregnancy guidelines. As far as the PowerPoint I helped create for American Headache Society, I don't think that's readily available. There's a lot of resource information. If you go to American Headache Society, you click on patient resources. Same thing with National Headache Foundation, also known as NHF. The website's super easy to remember. It's called headaches.org. So if you go to these reputable headache sites, which are not promotionally driven for any particular product, they're not pharmaceutically driven, you can listen to podcasts and get really good information on these topics. So once again, American Headache Society and National Headache Foundation.
And we'll make sure to include all those links in the show notes. You actually covered a lot that we had as separate questions. Are all the routes that triptans are delivered safe during pregnancy, such as injections, nasal, etc.?
Yeah, I believe they are. Again, my opinion may not be shared with everyone out there, but I really want the patient to not suffer with migraines. And I think which route really depends on how severe her migraine is. For example, if it's rapidly escalating, nausea, vomiting, boy, I'm going to go with an injection. Let's say there is some nausea, but not too bad, maybe the nasal delivery, because your oral route of administration is going to be the slowest to take effect. So I see Natalie nodding her head. Do you also agree that I think all forms of triptans are probably okay during pregnancy?
Yeah, I think so. And especially, if your patient's been used to doing the injection or the nasal spray, I don't think an oral hasn't worked in the past. It's really unlikely to work during pregnancy. So I wouldn't want to change what they've been using and what's been helpful for them too.
Completely agree. But you know what most women will tell you is that particularly when they move into their second trimester, their migraines are a lot less. And if you're wondering why, well, estradiol specifically, gets really high during pregnancy. And then about the second trimester and the third trimester, it stays high, but it's fairly even. So you don't have the ups and downs as a woman who's not pregnant. So that's one of the reasons why for many women, migraines do get better or improve, particularly by the second and third trimester.
Yeah, it's really nice for some women when they have that and they're like, wow, well, okay, things got better on their own. And how do you feel about nerve blocks during pregnancy? That's something I would very commonly use for pregnant.
Yeah, nerve blocks are considered very safe during pregnancy, and I believe that typically lidocaine is the preferred anesthetic that's used. I think bupivacaine would be okay, but the nice thing about nerve blocks is you're not getting systemic absorption. It's not getting into your blood system. And I think It's a great way to rescue when a woman with migraine is not doing well. Because, if you go to the emergency room and urgent care and you get a shot of something, well, that's okay, but it's not going to last as long. Your headache might come back the next day. So I think with a nerve block, you might be able to get relief for 4 to 14 days. And I think it doesn't have to be a one-time thing. If you're really struggling during pregnancy, I think you could probably have it every 2 or 3 weeks if you needed to get through that rough patch.
Yeah. There are times I would do them weekly if they really needed to and couldn't use anything else.
Yes. But we would not use steroids. Sometimes nerve blocks are done with steroids. And I think for pregnancy, you would just do the anesthetic. And I think in most cases, lidocaine is the one that's used. I will tell you that I think I and many headache specialists have used it because we're looking at the benefit versus the risk. There's a lot of medications that are not going to come right out and in the package inserts say it's safe. But when I think about Botox, it's injected superficially. It's intramuscular, but it's superficial. And you're really injecting around the nerve endings. You're not injecting into the blood system itself. So I personally feel there's very little systemic absorption. And boy, can it make a difference, particularly if I have a pregnant woman who's had to go to the emergency room because of the severity of her migraine. But I don't think I would start Botox during pregnancy if the woman never had it. More typical is the woman who's been getting Botox, doing pretty well, and then decides to stop it because of pregnancy. And of course, we hope that her migraines are going to get a lot better. But if they don't, and particularly a really reason for me to get back on the Botox would be certainly if the woman's having to go to the emergency room because of the severity of her migraines. And there have been some published studies that seem to indicate that probably Botox, again, I say probably, but it looks like it probably is compatible with pregnancy.
And is that what we've learned from the registries where we're seeing pregnant women on Botox?
Absolutely. And I think, one of the issues with registries is probably there's a lot of women getting these treatments and it's not being reported. So really encourage, if you're pregnant and your doctor's prescribing something like Botox, please make sure the provider's reporting it, because the larger the numbers in our registries, then that gives us that much more confidence with the relative safety of a medication.
Yeah, and it's nice that Botox has been around for a really long time for migraine prevention, and there's lots of kind of available data out there. So I also feel really comfortable with continuing Botox for my pregnant women. But I want to shift and talk about some of these newer medications. And you mentioned some of these kind of newer injectables that target CGRP or the CGRP monoclonal antibodies like Jovi, Emgality, or Vyepti. How do you feel about those, and what do we know about the safety of those in pregnancy?
Well, that you just hit on the key point. There's not enough numbers in the registry, so the reality is we just don't know. And what we call the half-life of these injectables is anywhere from 28 to 31 days. Complete elimination of any medication is 5 half-lives. So if you take 5 times 28 or 31 days, you're looking at 5 months. And so
Wow.
I'm not comfortable with that if we just don't yet know. Women, that's why I'd recommend seeing someone like me or Netta or whoever's treating your headache 6 months before, and allow us to switch you to a preventive that has a shorter half-life. So if you do find you're getting pregnant, you can stop it. And some of these oral tablets for prevention, they're out of your system in like 2 or 3 days. So I would much rather have a woman on something orally with a shorter half-life if she's actively trying to get pregnant.
I assume that also that logic applies to the G-pants as well, such as Nurtec or...
Yeah, with the oral G-pants, again, we just don't have enough data. But if I had a woman on an injectable CGRP mAb like Aimovig, and she wanted to try to get pregnant, and she was really reluctant to get off the Aimovig because maybe it had made a huge difference in her life, I would seriously consider switching her to Qulipta or to the one called Nurtec every other day. Those are oral G-pants. But both of them have an 11-hour half-life. So that means either of them, when stopped, will be out of the system in 55 hours. So a little over 2 days. And that way there's very, very little drug exposure for the. So I think that's another reason, again, to really see the headache provider months before you are actually trying to get pregnant.
Which preventive supplements for migraine are considered safe during pregnancy, and at what doses?
The 2 supplements that I consistently find that OBs are fine with and that have been published on are B2, which is riboflavin, and magnesium. The doses that I recommend for both is about 200 milligrams twice a day. I believe you can go higher with magnesium, but be careful because of diarrhea. Having said that, it's not uncommon for women to struggle with constipation as the fetus is developing. So when you think about it, the magnesium may help to both prevent migraine and to help with the constipation. I've never had an OB disagree with those two, which is B2 and magnesium.
What about some of the more common ones that are talked about, like CoQ10?
And I don't recommend during pregnancy because we just don't have enough data. If a woman was still struggling, let's say she was on B2 and magnesium and, she did the acetaminophen, she's still struggling. There's other things that can be done for prevention because we haven't really discussed yet non-pharmacological things. There are non-invasive devices such as the Cephally, the Nerivio device. There's GammaCore. There's a TMS device. So there's devices that I think would be safe. Things like acupuncture, pregnancy massage, physical therapy. There are so many different modalities that I think a woman could consider that would be not putting a medication in her system, and that could be quite helpful.
Yeah. I agree. There are so many options out there that are also like non-medication. And we talked a lot about medication options as well. But, let's say someone who's pregnant and has migraine is on a medication that we haven't talked about yet, or a treatment we haven't discussed yet. Who should she consult for guidance on pregnancy safety?
For pregnancy safety, again, I think if the woman provider wasn't sure, again, she could either ask to go to the high-risk OB, or she again could go to the National Headache Foundation, the American Headache Society, and get very good information. I'll just say that from my experience, high-risk OBs are much more comfortable with prescription medication than regular OBs. And I mean no disrespect to regular OBs, but sometimes the high-risk OB is the one that will really get into the detail, the weeds, if you will, of the risk versus the benefits. So if a woman's really, really struggling, I would say maybe ask to be referred, if not to a headache specialist. I mean, if they're in California, we'd be happy to see them. But a high-risk OB might be necessary in some cases.
Good to know.
What should a woman do if her OB is hesitant about a migraine? Or let me say that again. What should a woman do if her OB is hesitant about treating migraine at all during?
Well, that is a tough one. If the OB is not comfortable at all, maybe the patient could gently ask the OB, is there another OB in your practice who's more comfortable with migraine? Is there a family physician in internal medicine from your experience that would be comfortable co-managing? Because the OB has had other women that were pregnant with migraine. If the OB wasn't willing to do anything, then it might be time to switch to a different OB, quite frankly.
I mean, self-advocacy there is very important.
But when you think about, let's say most OBs are women, and so there's a 25% chance probably that either they have migraine, a family member, and so I think you are going to find OBs that are more comfortable treating migraine than other OBs. So, if a woman is starting to look at a potential OB and she's not yet pregnant, that might be an important question to ask as part of the interview process. Look, if I'm going to pick you as my OB, are you comfortable managing migraine and or comfortable co-managing me with my primary care provider?
That is a great tip.
Is there anything else you would like to add about migraine and pregnancy that we didn't go over?
I guess the main thing is to encourage women not to be afraid to get pregnant if you have migraine. Keeping in mind that for most of you, your migraines will improve, possibly even go away. But if they don't, there are medications and treatment strategies that we can safely recommend and prescribe so that you can still have the pregnancy and still be a mother. So don't put off motherhood because of migraine.
I think that's great advice.
Thank you so much, Susan, for joining us again. And we'll see you for the next episode in our series of migraine and postpartum.
Thank you. I look forward to joining you again.